Hi, everyone. Welcome to Sign Ask the Neurologist podcast series. I'm your host, Sahdev Baweja. I'm a first year medical student as well as a Sign e-board member. Today, I have the honor and privilege of interviewing Dr. Stephen Wolf. Dr. Stephen Wolf, thank you for coming on today.
How are you? Thank you so much for having me. So I'm Steve Wolf. I am the professor of clinical neurology and pediatrics at New York Medical College. I am also the director of pediatric epilepsy at Boston Children's Health Physicians of New York and Connecticut, as well as the director of pediatric epilepsy at Westchester Medical Center at the Maria Farrar Children's Hospital. Basically, I was going to tell you a little bit about my journey and how I ended up to where I am. So I was a 6-year medical student at Rensselaer Polytech and Albany Medical College back in the day when you could do 6-year medical programs. And then during my medical school, I got exposed to neurology and neurosurgery. I was always a little interested in those areas, though I almost went into internal medicine, gastroenterology. I was one of those guys who enjoyed everything. But when I got to my neurology clinic rotation, especially the child neurology, I really just liked the mix of the pediatric and the neurology part. And I liked the choice of the people that I was working with, and it just was a really upbeat area. And so I thought that was really sort of fascinating. But the part that really fascinated me the most about child neurology was just that there were all these new things coming around. That it was an area that hadn't blossomed yet. I was looking at areas of surgery and areas of gastroenterology, and they were all very, very developed. But neurology didn't have that many medications in epilepsy. The genetics, really, we hadn't solved all the genetic problems. And I really sort of had this idea that I wanted to be in a specialty that was sort of like at frontier medicine, that had all these new things that were sort of developing. And when I was a medical student, there was all these new things with genetics and new drugs that were about to come out. And I said, that's where I wanted to be. I wanted to be where new things were doing, and I could be sort of on the cutting edge and being involved with new things, even though I wasn't a bench researcher and I wasn't inventing new things. I wanted to be in that kind of population. And so that's sort of what triggered me. I always liked neurology, and not only did I want to be on something where everything was new. Someone said to me, when I asked them how you pick your specialty, they said, well, imagine you have a bunch of articles in front of you and you had a choice to read something. Would you want to read about gastroenterology, or would you rather read about some weird neurological issue? And I realized, and I realized I liked the neurological stuff. I liked the stories of the neurological stories. I liked being a detective and trying to piece out where the lesion was. And then, of course, I read Oliver Sacks's books, and I loved the way he told stories and how he dissected it out and came to a solution. So that was sort of how I picked it, was, being in an area that was sort of new and is going to keep developing, something that I enjoy reading about. And I found the intellectual excitement when someone described it to me is what sort of triggered it. And then I can envision myself doing it. And then also the population I was going to be working with. So at first, I was sort of very turned off by, seeing poor adult patients who were stroked out and very damaged. And then I started working with the kids, and I really saw that I could possibly bring something to the table and make the quality of their life better. And so I thought that was a real opportunity, especially if there were going to be new drugs and new surgical procedures and new devices. I thought that would be really exciting. And so that was what sort of attracted me into the area of getting into the child neurology world. And then I went down to Montefiore and did my pediatrics there. I did my neurology rotations there, finished my fellowship, and then I did a year in epilepsy. And that's when I became an attending at Montefiore, and then took some time while I was a junior attending to help a senior neurologist write a book on EEGs. And so I spent 2 years working part-time, seeing patients, and then writing a book. And then I went back to being clinical full-time, and then obviously moved from hospital to hospital and started building epilepsy programs. What's interesting, and when you're looking at your colleagues and you're picking a neurology specialty, is that sometimes when you look at these guys who are already neurologists, they have something that they do. But say they're only a clinician in the office, or this guy goes to the operating room and runs the machine. Um, there are many ways you could be a neurologist. So, for example, in the beginning, I really only focused on epilepsy and general child neurology and only doing drug trials. And then at one point, when my partner, Patty McGoldrick, joined me, we decided that we needed to offer other things besides medication. But during my residency training, I didn't get enough training in epilepsy surgery. So actually, while I was attending, we went and got special training in epilepsy surgery, and we went to Cleveland Clinic, and we went to Germany, and we went to France over basically a 5 or 6 year period to get trained in epilepsy surgery, which was just developing at that time, and I didn't get exposed to it to my residency, to a point that by 2000 we were able to open up our own epilepsy program at Beth Israel and start an epilepsy surgery program. So the point of that is sometimes you don't get everything that you want to be trained in during your residency. So it is important when you're looking at residency programs to see that they have all these different things that you can get exposed to, so you can decide whether you want to really expand into that area. Now, a lot of the residency programs have medication treatments, they have surgical treatments, but I didn't have that opportunity. Then the other thing that we were very interested in was genetics. And of course, there was no major genetic subspecialty back in the late 90s. And now there's a lot of genetics in neurology. So that became another area that we became sort of fascinated with about 10 years ago. And we started working really closely with geneticists. And we really got sort of a crash residency course in genetics, where we got involved with 2 NIH studies looking at genetics and epilepsy. So what I'm trying to tell you is your training never ends and curiosity never ends. And if you don't get something in your residency training, then you can go out and do it as an attending. And that's sort of why, going back to why did we pick neurology? Why did I pick neurology? Is because there's always something new that's coming down the pipe. And my career over the past almost 30 years has sort of weaved and changed a little bit. But actually, what I really do is add on other things that I learned to become the neurologist that I am now. I hope that makes a little bit of sense.
Yeah, thank you
Um,
so much for talking about your journey. After your 6 year medical school, how many years of residency and fellowship were it?
so for the child neurology fellowship and residency, I did 2 years of pediatrics, 3 years of neurology. That's 1 year of adult neurology, then 2 years of pediatric neurology fellow. Then I did a 1 year epilepsy fellowship. And now you have a choice of doing a 1 or a 2 year epilepsy fellowship, depending on what you want to do. And especially if you're going to be doing epilepsy surgery or if you're going to be doing epilepsy research, it depends on the program. So you sort of look at what's interesting. But when you apply for child neurology fellowship, you apply for that through the match at the same time as the pediatric match as well. So you can get both programs at the same time.
Thank you. So our next question is, what conditions do you treat, and what would you say is like the most common?
So in child neurology, I was trained to treat everything. And when I was a young child neurologist, I treated, epilepsy, migraines, ADHD, cerebral palsy, everything you possibly a general child neurologist would see. And I really felt that that was really important, especially while I was young, not to specialize too quickly, because you really need that experience to be a really good child neurologist before you specialize. Now that I'm a number of years down the road, I am more focused on epilepsy. Makes up literally about 80% of what we see. And then the other 20% is the headache and other neurological conditions that, are part of our practice. But early on, I recommend not super specializing, getting training in specializing, but don't super specialize because you'll miss the sort of the big picture. And I think being a well-rounded neurologist adds a lot to being a good clinician.
Thank you. What age range of patients would you say you see?
So that's really interesting. When I moved from Montefiore to Beth Israel, there was a multiply handicapped clinic that was there at what was called Roosevelt Hospital, and I became the medical director of that clinic. And that clinic, interestingly enough, had kids that were as young as birth all the way up to about 60 years old. And suddenly I was in this group of developmentally disabled pediatric and adult patients and the adult patients all had very difficult seizures. And so we've been running this program now for 27 years, and we're still running this program. And these are all Medicaid, Medicare patients. And I really enjoy taking care of the adults as well as the children with developmental disabilities. So our population is mixed. And so we are still taking care of adults who have developmental disabilities with epilepsy. And then what's interesting about this clinic is mainly Medicaid and Medicare. So basically what we really figured out is how I can have a private practice that takes regular insurances and work in a clinic population outside of what I normally do, and still take care of that population. And so myself and my partner, Patty McGoldrick, have really figured out how to create a world. And so you'll see that patients will suddenly lose insurance, their family will lose insurance, or if they're developmentally disabled, they will come off the parents' insurance and go on straight Medicaid. And we'll be able to move them from our private clinic into our Medicaid clinic and still get them the same good quality of care. And so that's been really important to us over the past 27 years. And we've been able to provide that in the clinic setting. So we work at a program in Manhattan called YAI, Young Adult Institute. And there's a program there called Premier Healthcare. And we're able to do that as well as work up here in Westchester and at Boston Children's and provide the care for the patients up here as well. So it's very rewarding not to lose touch and make sure that every population of patients gets the experience, the skills that you bring to the table.
Thank you so much. So the next couple of questions will ask a little bit about your work-life balance. So if you could say like how many hours a week or a day you generally work.
Yeah, so that's a good chuckle. In the beginning, my kids were young, as well as my partner Patty's kids were young. And so there were a lot of school things and life things that happened. And because we worked as a team and we both had young kids, we would cover for each other and make sure that the stuff that our kids needed to do, each one of us would cover each other so those things would get done. And I think we've done a really good job. My son's now 27, 20. So my kids are older. So when we're younger, it was really important making sure that we got vacations, we got time, but when we worked hard. But, there was a time when I took them to a swimming lesson or I had to get to a school play, and I made sure that I had a partner that I could count on and had my back. And when those last minute things happened, we had it all covered and taken care of, and we really planned it out together. So making sure you have an awesome partner to do this with is key to make sure, especially while your kids are young, that you can do that and you can and have a life. We do work a lot of hours. We're in the hospital by 7:30 in the morning and trying to get out of the office, seeing patients around by about 5. But then we still have to do telephone calls, and I have a lot of EEGs. So my clinical work is long. And we are also running drug studies and we have surgical studies going on. So it has been a little tricky trying to create a balance. And sometimes I do get scolded at by my spouse when I'm still reading EEGs at night while they're watching TV. But I really try to pay attention and keep track of this. Interestingly enough, it was actually easier before electronic medical records. Electronic medical records have slowed things down, and we really had to work on creating little templates and shortcuts to get things done faster in this world of electronics. So things that made things easier actually made them a little bit more complicated. But you really got to create systems for yourself, shortcuts, be clever, talk to other people to make things much more efficient, and really divide and conquer, and to really have a good team approach. Try not to do everything yourself, work as a team. You'll find that it'll be much actually more rewarding. For me, having a partner that is literally right next to me, to be able to go next door and say, hey, what do you think about this? Can I pick your brain? Can you come see this patient? To me, that's huge. Because it makes it much more enjoyable. You have somebody that you're suffering with and working hard with, but you don't have somebody really bounce something off and not working in isolation. So I think to me that has made the journey much more dealable. And then your next question is, do I go on vacation? Yes, we use every single day possible. And again, having a good partner relationship is what makes that possible, and really turning your brain off and trying to get that. And on the weekends, back in the day, we work on the weekends, but then if I had to go take my kid to archery or to soccer, I'd make sure that we get out of there fast, get it done so we can go and be with the family. So it's really important. But the part of your career is your career can change. You can change pathways halfway through. You can decide, I don't want to do research, I just want to be clinical, or I want to just do clinical, I want to do a research. There's no rules of what you can do and what you can't do. I think if someone told me that I'd be at this point doing clinical and research and running a hospital program, I would say, nah, that wasn't me. But things change. My desires change, my interests change over time, and there's nothing wrong with that. It is no set path, and that path will keep changing as I change my mind, my partner changes her mind, what we think is the next interesting thing to do.
Thank you so much. So since you mentioned that you do both clinical and you do research and obviously involved in teaching students and residents, how much of your time you spend in a typical week is clinical versus research versus other stuff?
I would say the clinical makes up 90%, would you say, Patty? 90% of what we do. About 10 to 10% is the research. And the reason we're able to get that down to 10% is that we've delegated. So over the years, we've hired numerous clinical research coordinators, and that's really an art of working with people, and then enrolling the other clinicians to also help out and to create a team. And I think that's really made a huge difference in being able to produce the amount of work that we produce in this process. So I would say that's basically how it's sort of split up.
Okay. Um, the next question I have for you is, what advice do you have to aspiring neurologists?
Well, one is, get to know other neurologists, and don't just meet one, meet multiple ones, and you'll see that everyone is very different. Some have really bad sense of humor, some have really good sense of humors. Every program, every residency program is different. But if it's something that tickles you and it's an area that's interesting to you, just be open to everything. When you go in as a resident, don't think you're going to specialize. Go and experience every part of neurology, and then see what area really inspires you. And I think that will sort of guide you along.
Thank you. And how do you see the field of neurology changing in the next 10, 20 years?
Well, I think the next 10 or 20 years, genetics is going to have a huge impact on it. So I recommend learning a lot about that. I think genetic treatments are really going to be sort of the fascinating new treatments. I think neurostimulation, what we're using right now, is going to be really key. And we're so in the infancy of how neurostimulation or computer interface into brains right now is so not even at the beginning infancy stage. I think that there'll be so many new things coming along that'll be really sort of fascinating. I think this area is just going to keep growing and changing.
Okay. And so our last question that we like to ask everyone is, what is your favorite part of the brain or CNS and why?
So my favorite part this month is the thalamus. Patty's in my research. has been doing neurostimulation on the thalamus for control of epilepsy. We are fascinated by the central median nucleus, the anterior thalamic nucleus, and the pulvinar. And if you really want to know more about it, you can come hang out with us in our office hours. We'll give you some articles, and you can see all the new things that we're doing on neurostimulation. So thalamus power tube. Thalamus is the power center.
Thank you so much for your time, Dr. Wolf.
All right, have a great day.